So today we'll be discussing about the tumors of the oral cavity, its precancerous and cancerous lesions of the oral cavity. Now, before starting the tumors of the oral cavity, we should know the precancerous lesions of the oral cavity. The precancerous lesions are lichen planus, leukoplakia, and erythroplakia. This leukoplakia, erythroplakia, and dysplasia, they are an abnormal area in the mouth, or the leukoplakia looks like a white area in the oral mucosa, whereas the erythroplakia is a slightly raised red area that bleeds easily if we try to scrape it out. These white or red areas, it may be cancer or they may be a precancerous conditions. This precancerous conditions is known as dysplasia, and they could also be some relatively harmless condition also. So all leukoplakia and erythroplakia do not turn in the cancer, but they are likely to turn into the cancer. Now coming to the oral leukoplakia, is characterized by a white patch on the buccal mucosa or any place in the mouth, and it's mainly present adjacent to the place where the tobacco quid is kept. Although 90% at this site,
the slight tumors of oral cavity में अड्किरहेछ.
यसमै अड्केको छ. Can you see?
सर देख्न चाहिँ देखिरहेछ, चेन्ज चाहिँ भएको छैन. No, sir. Boy, sir, अहिले.
The net is quite slow, I think, here. Can you see leukoplakia, erythroplakia, and dysplasia?
Yes, sir.
I think it has already been covered in the last topic. Was it covered? So leukoplakia is a white area and erythroplakia is a slightly raised red area. And in this leukoplakia and erythroplakia, the erythroplakia has more likely to be transferred into the cancerous of transmission into cancer, whereas the erythroplakia is more than 20% to transfer into a cancerous lesion. These all conditions are the precancerous conditions known as dysplasia. And sometimes the dysplasia may also be a harmless condition. All the dysplasia does not turn into the cancer. Now coming to the oral leukoplakia, it is characterized by white patch on the buccal mucosa or any place in the mouth. It is adjacent to the place where the tobacco quid is kept. The less likely place is floor of the mouth and tongue, because usually the tobacco quid is kept in between the gum and the oral mucosa or lips. But the leukoplakia at this site, like floor of the mouth and tongue, they are more convert into a malignancy than the other site. Now you can see a picture of the leukoplakia. You can see here, this is a whitish lesion. This is a leukoplakia. This is also leukoplakia whitish lesion in the buccal mucosa and the gums. And see, this is the erythroplakia. It's quite different.
Slide change भइरहेको छैन, sir.
अहिले कहाँ छ? Where is the slide now?
Leukoplakia, erythroplakia. कर्सरबाटै यतापट्टिको साइडमा कर्सरबाटै थिच्यो भने चाहिँ हुन्छ.
Okay. आयो. Now it's With the slide, can you see the picture?
सर त्यो कर्सरबाटै चलाएर यता स्लाइड गर्यो छैन
पिक्चर with the slide कहाँ छ अहिले
ल्युकोप्लेकिया इराइथ्रोप्लेकिया र डिस्प्लेजिया
मा अड्क्यो wait a minute slide now can you see the picture
नो सर स्लाइडै आएको छैन
Can you see the slide now? Slide is share भइरहेको छैन कि Now can you see the slide?
नो सर
Slide नै आइरहेको छैन
स्क्रिन शेयर गरिहाल्छ
गरिरहेको छु शेयर भइरहेछ नि
चेन्ज मात्र भयो
इनेबल एडिटिङ गर्नु छ कि Now
नो सर
स्क्रिनमा के आइरहेछ अहिले
सर स्लाइड देखिरहेको छैन
कहाँ गयो महेश स्लाइडै सेयर भयो भने सेयर हुनुपर्ने नेट कम भएको अन्त सेयर भइरहेछ
I know more sad.
नमस्ते अनि स्क्रिन सेयर त भयो आएन किन त्यहाँ आएकै छैन भन्छ डेस्कबाट आयो अब
हजुर सर आयो
Okay, this is the lesion of the erythroplakia vitis membrane in the mucosa of the oral cavity. See, this is the vitis membrane. This is also leukoplakia, and this is the red part. This red velvety patch. This is the erythroplakia. This is characterized by red velvety patch, and it is not associated with any trauma or inflammation. It may also present with or without leukoplakia. And this lesion is easily missed out, but it is considered to have a great malignant potential. It's more than the leukoplakia. And coming to the malignant tumors of the oral cavity, more than 90% of the cancer of the oral cavity and oropharynx are squamous cell carcinoma, also known as squamous cell cancer. And invasive means that the cancer cells have spread beyond this layer into the deeper layer, from the mucosa to submucosa of the oral cavity or oropharynx. And these squamous cells, they are usually flat, scale-like cells that normally form the lining of the oral cavity and oropharynx. Now, coming to the risk factors of the tumors of the oral cavity, the most common is the tobacco and alcohol. The tobacco accounts for the 90% of people with oral cavity and oropharyngeal cancer. And alcohol drinking strongly increases the smoker's risk of developing oral cavity and oropharyngeal cancer. Other are the UV light or ultraviolet light. More than 30% of the patients with cancers of the lip have outdoor occupations associated with prolonged exposure to the sunlight. And irritation with long-term irritation to the lining of the mouth caused by poor fitting dentures may also lead to the formation of the C of the oral cavity. Other risk factors include poor nutrition, like diet low in fruits and vegetables, are associated with increased risk. Other mouthwash, there are some studies have suggested that mouthwash which has got a very high alcohol content may lead to the formation of mucosa into the cancerous cells. Other is the human papilloma virus infections or depression of the immune system. And other is the age. The likelihood of developing oral and oropharyngeal cancer increases with age, especially after age 35. So it's a disease of old age. And gender, this oral cancers is twice as common in men than women. The most common risk factor is tobacco, which is consumed in the form of different form like gudkha, weed, pan, or smoking. The gudkha is a flavored tobacco, the mixture with betel nut lime and harmful additive like magnesium carbonate, and is extremely addictive and is apparently targeted as youngsters. And quid is a mixture of tobacco and lime that has been extensively consumed. This tobacco and alcohol, they can damage the cells in the lining of the oral cavity and oropharynx, and that cells in this layer must grow more rapidly to repair this damage. And many of the chemicals found in tobacco cause the damage to the DNA of the cell, which contains the cell's instructions for repair and growth, which may lead to the formation of the cancerous lesion. Scientists, they are not sure whether alcohol directly damages DNA, but they have shown that alcohol increases the penetration of many DNA damaging chemicals into cells. Now the detection and diagnosis of the oral cancer. Many cancers of the oral cavity and oropharynx can be found early during routine screening examinations by a doctor or dentist or by the self-examination. Initially, the oral cancer, it may be asymptomatic, but a checkup of a small ulcerative lesion from a professional is recommended. So patients normally present when pain and discomfort is predominant, and then the prognosis becomes poor. The pain and discomfort is a very late feature of the cancer. So once we give some abnormal structure in the oral cavity, then they should get examined by the doctor. The patient should not be wait till the patient because the pain and discomfort are the late features of the tumor of the oral cavity. Diagnosis is established by many ways, like applying dyes like toluidine blue, using X-rays and scan to see the extension of the lesion and bony involvement. And the most confirmatory test is biopsy of the lesion and its histopathological examination. So if someone asks you how to diagnose a tumor of the oral cavity, then your answer should be it's a biopsy of the tumor. It's the main important is rather than applying dyes and using X-rays, the most confirmatory test is the biopsy. So you have to answer the biopsy. Symptoms: there may be a sore in the mouth that does not heal. Most common symptom, there is ulceration in the oral cavity which does not heal, or pain in the mouth that does not go away, and other is the persistent lump or thickening in the cheek, or a persistent white or red patch on the gums, tongue, tonsil, or lining of the mouth, a sore throat or feeling like something is caught in the throat that does not go away. You can see there's a tumor. Other symptoms include difficulty in chewing or swallowing, difficulty moving the jaw or tongue, swelling of the jaw which causes dentures to fit poorly or become uncomfortable, loosening of the teeth or pain around the teeth or jaw. If the tumor grows more inside, there will be change in the voice, a lump or mass in the neck because of the lymph node metastasis, and weight loss, and persistent bad breath. The origin of the tumor of the oral cavity, it normally starts from any of the precancerous lesion in the mouth. The most common site of the oral cancer is the tongue and the floor of the mouth. The other common sites are buccal vestibule, buccal mucosa, gingiva, and rarely hard and soft palate. And cancer of the buccopharyngeal mucosa is common in smokers. Now coming to the CA tongue or carcinoma of the tongue, the origin, it may start as a small ulcer in the tongue, usually most commonly in the lateral border of the anterior two-thirds of the tongue. The presentation may be various, like there may be a small papillary exophytic lesion, or sometimes there may be a flat nodule, or there may be ulceration within a pre-existing fissure, or it may occur in the absence of frank ulceration in an atrophic tongue. And CA tongue is most common in the male and in old age, 50 to 70 years. The CA tongue, they spread into the muscles, causing ankyloglossia, and may spread to the floor of the mouth, alveolus, and mandible. And from tongue, the lymphatic spread is up to the upper deep cervical nodes, submandibular lymph nodes, lower deep cervical nodes, and submental lymph nodes. And it may, if there is a tumor in the middle, then it can go in the either side of the lymph nodes, in both sides. It may involve both sides of the lymph node. You can see there is a lesion, early lesion are painless, and patient may remain asymptomatic for a long time. Sometimes the cervical nodes are the first sign, while the primary is still asymptomatic. The patient may complain of the swelling in the neck. And on examination of the tongue, we can get there is ulceration in the tongue, which might be painless. So patient is not knowing about that. Once ulceration has occurred, the lesion becomes painful. Here you can see there is ulceration. The lesion becomes painful, making speech and swallowing difficult, and leads to the slurring of the speech and bleeding from the mouth. See, there is a tongue cancer which rapidly extends to involve the floor of the mouth, lower alveolus, and which makes treatment very difficult. Other site is the buccal mucosa. Buccal sulcus, where pan or tobacco quid is kept, is the other site for the tumor. Grossly, the lesion is exophytic or ulcerative, but later it may become infiltrative to the deep submucosa. Buccal cancer extends anteriorly to the lip and commissures. Deeply, it may penetrate and present on the skin, come out from externally, and posteriorly to retromolar trigone, pterygoid muscles, and jaw bones. And the buccal cancer, the lymph node metastasis is level 1A and 2, jugular-digastric lymph node. See, there is a tumor of the buccal mucosa. And here is coming out. This is the external part, same patient with the cancer lesion coming extraorally. See, there is a tumor of the buccal mucosa going extraorally. This is the extraoral part. Now coming to the other side is the gingiva. This is also called alveolar ridge carcinoma. It's also similarly predominantly in the male. The site is lower jaw behind the first molar. It's lower jaw behind the first molar, and it may spread to the cheek, floor of the mouth. From here, it may go into the floor of the mouth. It may go back to the retromolar trigone, or it go up towards the hard palate, and it may involve the jawbone, mandible, and rapidly spread along the neuromuscular bundle. And the lymph node metastasis is level 1B, and the jugular-digastric lymph node is level 2. Now coming to the cancer of the gingiva and buccal mucosa, the lesion is usually painless in early stages, and only when it becomes ulcerated and secondarily infected or invades the adjacent nerve, then the patient may have pain. And this pain is very noticeable feature, and the tumor is usually at the level of the occlusal plane or below this plane. They may be proliferative, warty exophytic growth with little fixation, or deeply ulcerative invasion may be seen. The proliferative lesion, though it looks dangerous, is easily treatable, and long-term prognosis is good as the metastasis to the local lymph nodes is late. Whereas the ulcerative lesion is not so easily noticeable, ulcerative and infiltrative. These are the very dangerous. These also ulcerative and infiltrative lesions, they are not easily noticeable and in early stages, but is more dangerous because of their invasive nature, and the metastasis to the local lymph node is very early. Now the other site is the lip. It's also common in male 40 to 70 years, and lower lip. There is more predominance in the lower lip than the upper lip. Site is between the midline and the midline and the commissure. The most common site is this one, in between the commissure and the midline. The tumor may be ulcerative or exophytic. Lymph node metastasis is late, but the metastasis is to the group 1A and 1B, and later it may involve the group 2 and 3 also. Another site is the carcinoma of the palate. In the carcinoma of the palate, the most common is squamous cell carcinoma, but there may be high chance of the adenoid cystic carcinoma also. And the carcinoma of palate is most related with reverse smoking. The CA starts as asymptomatic, painless superficial ulcer with rolled out edges. It may spread to the gingiva, lip, soft palate, or bone of hard palate, floor of the nasal cavity, or antrum. And the lymph node metastasis is towards the level 1B and 2. Now coming to the carcinoma of the floor of the mouth, it's also common in the male. Male is to female ratio is 4:1. It starts anteriorly near the opening of the submandibular duct, and the obstruction leads to the enlargement of the submandibular gland in the same side. The lesion, it may be ulcerative or infiltrative. The spread to the surrounding areas like vent, the tongue, lingual gingiva, mandibular periosteum, and deep to the floor of mouth and submental space. And lymph node metastasis is common in the level 1B. The carcinoma of the floor of mouth may remain asymptomatic for long, but may present as irregularities or soreness in the floor of the mouth. And carcinoma of the retromolar trigon. It may be primary or secondary to the extension of the growth from the either floor of the mouth or from the buccal mucosa or palate. Now coming to the treatment of the tumors of the cancers of the oral cavity, tongue, early lesions without nodes, we can go for the wedge resection or by interstitial radiotherapy. The larger lesions, if the lesion size is more than 1 centimeter, we have to go for the hemiglossectomy with 1 centimeter margin, that is adjacent tissue, plus neck dissection. If the lymph nodes are also negative, there is no lymph node metastasis, but we have to do the neck dissections in the larger lesions because we can find out the micrometastasis. In the lip, surgery with adequate margin, and if there is an involvement of lymph node, it requires block dissection of the neck dissection also. Radiotherapy also gives good results in early lesions. Buccal mucosa, small early lesions, go for surgery or radiotherapy, any one of them. If there is extensive lesion, then we can go for surgery, neck dissection, followed by the chemotherapy and radiotherapy. Palate, small lesions, we have to excise the lesions plus underlying bone. If the lesion is very extensive, we have to go for the maxillectomy followed by the neck dissection. In gingiva, all lesions, we can go for radiotherapy. So in gingiva, radiotherapy is not good. So all lesions, local excision with marginal mandibulectomy. And if the lesion is very extensive, we have to go for segmental or hemimandibulectomy. But radiotherapy is not good for the tumors of the gingiva. The tumors of the floor of the mouth, small lesion, it's surgery or radiotherapy, any one of these. Extensive, we have to go for the wide excision with mandibulectomy and block dissection. And utomolar trigon, wide excision plus block dissection, or we have to go for the commando operation. This commando operation, the full form is combined mandibular dissection, neck dissection, and oral dissection. These are the malignant tumors of the oral cavity. Now, other benign oral cavity tumors, they are common like papilloma, pleomorphic adenoma, hemangiomas, neurolemomas, neurofibromas, leiomyomas, rhabdomyomas, and lipomas. They all are diagnosed by the biopsy from the by the clinical examination. We can see a pedunculated growth in the oral cavity, which is a papilloma, and these all are pedunculated with the mobile, soft tumors, and diagnosis is done by the biopsy. And once the biopsy is confirmed with the benign tumors, then we can go for the excision of the benign tumors in all. Thank you. Is there any question?